I will talk about the ones that are really relevant because.
Thank you very much, Dr. Dabo. A quick intervention. For those of us who will not be sleeping tonight, we would encourage you to do your checkout by 12 today. Otherwise, if you go beyond 12, we'll be paying full cost for today as well. So please, those who are not sleeping, we will try and then check out. So you can just get your bag out and then you continue. Thank you very much. Yeah, so it's 11. So 12, you should be out. 12, you should be out of it.
Okay, so like I said, if we were given even the whole day, I will not exhaust talking about vascular interventions because it is quite broad and involves a lot of structures. But I'm going to just mention a few of some of the things we do in terms of lower limb and vascular interventions, renal artery interventions, hepatic, central venous angioplasty, aortic, of course, our fibroid embolization and bronchial artery embolization. I will start with the renal artery. Most times, we have patients who would have done renal transplants. And a lot of the time, this happens in India, and the patients come back home. Within a few weeks, normally within 8 weeks, you see that this patient, their BP will start rising, and sometimes it is uncontrollable. A simple ultrasound or MRA or CTA will show you that they have renal artery stenosis. And remember, especially for the residents, normally the implantation happens in the right iliac fossa, and they connect the renal artery to the what? External iliac. So you don't connect it to the aorta. So normally it will be in the right iliac fossa. This is an example of a patient who had a focal renal artery stenosis. In this case, we managed to put a wire across this one and then do just regular angioplasty. You just balloon it, open it, and you have saved somebody all the medication they are going to take and all the effects of the BP. In some instances, angioplasty alone will not work. And so in those cases, you go ahead and deploy a stent. So this is before, you can see the stenosis here, and then this is after it has been opened up. There are instances where also we do embolization. Please, my resident, when you see all these things, they are not calcium. These are embolization coils. So there are instances where people have renal angiomyolipoma. And for those ones, if it approaches 5 cm, it is an indication for treatment and an indication for embolization because they will bleed and die if you don't do anything about it. And especially for people who have hypertension coexisting with this condition. So this is a patient, after the devascularization, you can see that normally we try to spare the kidney. So we are not going to embolize all the arteries. Otherwise, you lose the kidney. So we select, if it's in the lower pole, you go to the lower segment, select the arteries there and embolize and save the top of the kidney. That's the whole point why you want to avoid surgery anyway. You don't want to go and take out somebody's kidney like that. Now I'll talk about the lower limb. I'm just going to start with some case history. So this is an 89-year-old woman. When I saw her 89, you would think she's about 60 years old. Very strong woman. She had a history of atrial fibrillation and they put her on warfarin. Unfortunately, she knocked her head against a wall and she had a subarachnoid hemorrhage. Because of that, they had to stop the anticoagulation. Now, once the anticoagulation was stopped, it means that again now there's a risk for embolus to go into the vessels anyway. And this happened exactly after a couple of weeks. And normally you can tell the difference if it is a thrombus or an emboli which is coming from somewhere, just knowing and taking a good history. So this woman came in initially. When we did the angiogram, you could not visualize anything. The vessel was coming from here, the iliacs, but the common femoral artery, it cuts off from here and you don't see anything again. So we put in a wire, put in some balloons, macerated the clots, and then draw as many as we could, as much as we could. And this is the result after that procedure. And again, this was getting towards the knee. The good and bad news here is that I managed to save this patient's leg below the knee because she still needed amputation. Below the knee, I couldn't save it, but at least I managed to save from the groin down to the knee. So these are some of the images after. Initially, you couldn't see anything at all. This is a second patient who is 65-year-old female diabetic with non-healing ulcer. As small as it is, it had been there for a lot of months. This is just a week after the intervention. You can now see the erythema, the pus has cleared, and this is what the angiogram showed. Just some 1 to 2 centimeter area of focal, about 90% stenosis. We put in a wire across, we balloon, and this is the effect after the angioplasty. And this is why she was healing rapidly after the procedure. This is why the balloon was up. This is how the balloon looks like, very small, and that's the wire going down. This is another patient. As you can see, a big wound, non-healing, infected. The angiogram showed a long segment occlusion. This was from the proximal superficial femoral artery all the way nearly to the popliteal. After a long battle, we managed to get a wire across it, across the occlusion. In fact, there are instances you cannot even cross from here, so you have to now go retrograde and try to puncture from the popliteal artery and come out. Because here I am approaching using the antegrade approach from the common femoral artery. So you put your sheath in the groin, put the wire down, and try to manipulate across the occlusion. In some cases, you do the opposite. And this is when we balloon down. So for the same thing that you couldn't see any flow here, a lot of collaterals coming off, and the wire now going through to the true lumen of the popliteal. This is what we got after. And just a few weeks after, the same wound here, in about just a month. Now, one of the things that I see a lot these days is people coming with venous ulcers, and because maybe they are diabetic or have some risk factors, people think that they are arterial. So I just put this out there to be able to tell the differences between arterial and venous. Normally, your Doppler will give you enough information, but I see that a lot of people don't do Dopplers for venous insufficiency, or don't do the proper thing for venous insufficiency. We just do and say, okay, there's no DVT, you see this and that. It's a whole lesson on itself. So basically, if somebody comes to you, Dr. Siama, you are welcome. Some people come to you with ulcers and you are not sure whether it's of venous origin or arterial origin. What do you do? First, you can start with, after your physical examination, which is key because history and physical examination sometimes will be enough. So let's not ignore our basics. That will be enough to tell you whether this is a venous ulcer or arterial ulcer. Beyond that, you can do a simple ABI, which yesterday Madam President spoke about. And I mentioned that these days we really have digital machines which will just generate the figure for you within a few minutes. And so once the ABI is suggestive, you can then go ahead and do either take the patient onto the table and do a straight angiogram plus angioplasty stenting, or you can decide to do a CT angiogram to further characterize what the problem is. If that is normal and you suspect it's a venous origin, then you have to do a proper scan to ensure that there's no valvular incompetence or venous insufficiency. This is what yesterday Dr. Webber spoke about. So you can have some differentials as well from, this was supposed to be differential for leg pain actually, because a lot of people who come with claudication, sometimes it's not vascular, it's not of vascular origin. So people come with claudication, they have ulcers on their legs. You have to consider other differentials. Sometimes it may even be some sort of degenerative disease process going on in the lumbar spine. And so keep your differentials in mind. Yeah, so we are trying to save a lot of people from amputation because it can be very traumatic. And the last thing you want to do is to know that you could have done something to save a leg, but then nothing was done until the patient lost it. And so we want to avoid seeing our patients with all the prostheses and all the amputation. Thanks to this man, he's a chief somewhere from the Acute areas, and he gave me a lunch because he had this ulcer which was not healing for the longest time. And so someone told him to come and see me, a doctor from 37. And there was a festival coming up, and he says for the chief they have to wear the traditional slippers. So he couldn't afford to wear anything to cover this. And we did the treatment within 4 weeks. The wound was totally healed, and he was able to go to his festival. Okay, this one also, this was a doctor's dad who came. I was trying to show the prior image, and which I don't have, but again, he had intervention and the wound began to clear up. This is what sometimes people refer to me at this stage. I mean, one of the things people have to know is for intervention, it's only for wound healing by increasing blood supply. But you can't reverse a gangrenous process. So when people come, when I saw this, I was actually, anyway, let me reserve my comment. But we still get patients like this coming to us, hoping that something can be done about it. And that is why I showed all the other images. When they are in a certain stage with small wounds, ulcers, claudication, that is the best time for us to intervene. You don't wait for it to get to this stage before you send to us, because at this stage, I can't do anything about it. And we have to send the patient back. The last thing I'll talk about is venous insufficiency. So in a normal situation, we know that you have your superficial and deep veins, and blood normally flows in one direction. The valves will open up, allow the blood flow, and close up. But for some people, there's incompetence of these valves, and so there is more like regurgitation of the blood, and eventually leads to pooling of blood. You see your varicose veins, leg swelling, leg pain, and eventually leg ulcers. It's a big problem around the world, and it is estimated that globally there are 7.1 billion people with this condition, but only about 1/7 get to be treated. And you look at the distribution in America, maybe 25% of people are getting treatment, same as in Europe, 2.5, of which 0.66 million are getting treated. But Africa, that is outside of the US and Europe, we have estimated 3.5 million people, and only a tiny fraction gets treatment. These are the different grades. So you can start from C1 up to C6. I normally do not treat C1, it's just for cosmetic reasons. And for C1, we can just do sclerotherapy and close off this. But the ones that can be threatening to your leg are from C3 up to C6. And we see a lot of people, sometimes they have hyperpigmentation and they think it's some sort of weather-related condition or something. They've had it for years. And eventually it progresses, and then they get this. Almost all the patients I have seen come in this stage. Only one or two come at this stage. So this is a young lady who was working in Kolegu. I mean, she used to. And she had this. She had leg pain. And for her, she was only worried about the cosmetic effect, that she couldn't wear her shorts and couldn't wear short skirts. So she came, we did the evaluation, and she had some valvular incompetence. This is another person who came, and typically this is how you see the ulcer. It's somewhere in this region, either medial or lateral, but most times around the medial malleolar region. So in the past, our surgeons, our friends were doing stripping as treatment for this. But today, nobody does that again. Nobody does that. And if you look at the criteria from NICE, the number one recommendation is to do radio frequency ablation or endothermal treatment. And we do have the machine. The machine looks like this. You just need to get your ultrasound, and then there's a long catheter. And so what you do is that you, under ultrasound guidance, try and get access into the greater saphenous vein, just around the knee or below the knee. And then you put the catheter in all the way to the saphenofemoral junction. Once you get to the saphenofemoral junction, you pull it back like 1 centimeter. And then you switch on. It has its own generator, its own mechanism. You just switch on the generator. And within 30 seconds, it will cause an ablation. It will virtually cook the vein. And then you'll be drawing back till you get to your entry point. So you end up cooking from the groin all the way to the knee. And that is all you need to do. After that, the blood cannot now come back into the greater saphenous vein again. And over time, the wound will start healing, the skin will start changing color, and all the symptoms will reverse. And it can be done in less than 30 minutes. I'm going to end just to mention some of the vascular procedures again, which we're currently doing. So lower limb, we do the angiogram, angioplasty, plus or minus stenting, thrombolysis, and again, let me mention that if you see anybody who reports to you with acute leg pain, especially with hyperpigmentation, with all those other changes, pallor, pain, please do not ignore it. And don't always call it DVT. Especially if the patient has risk factors. Always ask for a Doppler basic evaluation. Because sometimes we see people who have acute leg pain and they sit down there till the leg starts rotting. There's a student who came from Cape Coast recently, just about 34-year-old, that I saw at cardio. He had all the symptoms, but he delayed and delayed and delayed till he came when we couldn't do anything about it but to amputate the leg. And he was only 30-something years old. So if you get someone with cold leg, pain, pallor, please always make sure that the patient gets some sort of evaluation because you may end up saving that leg. And these things are time sensitive. The earlier you intervene, the better the outcome. If you don't do anything about this within a few days, the leg is gone and you can't reverse it again. So thrombolysis is something very dear to my heart because it's something that is preventable, something that you can do something about. And we have a lot of patients also HCC. HCC has now overtaken prostate cancer as the #1 cancer amongst men, according to the new data that we have. So HCC in our environment is something that we are battling with. And for most of the patients, even in America, the data shows that about 80% of the people who come and they are not surgical candidates. So imagine what happens in our environment. What do we do for those people? So we are able to do chemoembolization for those who are in the intermediate stage. For those who are in the early stage, Dr. Babiapa, we've done a lot of microwave ablations for early tumors. People have up to 3 centimeter, 4 centimeter nodules, and they achieve complete resolution. Complete resolution. You do alpha fetoprotein would have returned to normal in the patient. Of course, there can be recurrence in the future, but at that stage, if you're able to offer such simple treatment to the patient, you'd have saved a life. Beyond that, those who go to the intermediate phase, who have about 5 cm, 10 cm tumors, we do the chemoembolization for them. And we have an MDT, multi-department meeting, where we decide who gets which treatment, because we also have surgical approaches. So for those who are surgical candidates also, our surgeons will take them in and operate on them. And then fibroid embolization, UFI, bronchial artery embolization. Sometimes people get massive hemoptysis from lung CA, sometimes from tuberculosis, and you can do an embolization procedure to stop all of that. IBC filter insertion, those are like ABCs of IR. We do that almost every time. I talked about venous insufficiency and varicose treatment. And of course, we are now doing EVAS, endovascular aneurysmal repair of the aorta. So these days, we can put in a stent without even cutting open. The vascular surgeon does a cut down for us, and we go work together, put in the stent, patient go back. We also do maintenance of graft and fistula. We don't create them. I'm not a surgeon, but we maintain them for those who get stenosis, those who get thrombosis. Because the truth is that you have limited number of veins on your body. So if this one gets thrombosed or has a stenosis and you don't fix it, they'll go and create a new one here. If a problem comes, they will keep creating. There's a patient, somebody, a popular TV presenter, who they exhausted all the lines. All of them. So they will know where to now do dialysis. So they called me and I did a translumbar and put in the catheter in the IVC straight away. So that at least you can continue to get the dialysis done until whenever. So it's important that we try to maintain those lines when they get issues because they are not inexhaustible. And then the non-vascular procedures, hepatobiliary interventions, of course, the abscess drainages. I mentioned microwave tumor ablation, biliary stenting and drainages as well, the frostomy, spec tubes, and that is the end of today's presentation. Thank you.
Thank you very much. Any questions? Any questions?
Thank you for your presentation. This one, just a question. I want to ask, how often do you do canal central lines, like temporal and dependent?
So I believe that most of these procedures, depending on your center, you may be doing certain numbers. As a fellow, these were some of the ABCs of our practice, tunnel lines. You created them every day. Here, the nephrologists try to do them without image guidance. My colleague who went to TNT, Trinidad and Tobago, was not doing them because nephrologists were doing them until a point where their Minister of Education came in and they mistakenly ruptured the subclavian vein and he died. So it became a big issue, national issue, and they decided that they should not do it again. It should only be done by the IRB when then he became overwhelmed. Because then he was now doing everything. You know, so I haven't done many here. They send the ones that are difficult for them to me. When they do it and it fails, or they try the right side, which is the easier side, and they see it's not working, then they bring it to me, I put it on the left side for them. So that is how we'll be doing it here.
Thank you. A member on the floor wants to find out cost
Sorry?
ablation.
I'm sorry, I don't know the cost. And it's true because I ask people to go and buy whatever we need for the items, and then they come, and then I will charge my small fee if it's in private place, and that's how it works. So I don't know. I always give them a list of items, and I help them show them where they can get some to go and buy. And when they come, I do it. So I'm not into the costing, unfortunately.
Yeah, but to see how much you charge, the small book, please, you can see in chambers. Thank you very much.
Thank you very much, Dr. Benjamin Sarkodie. So we have come to the end of this very part. We would have a very quick snack break, still posterior to the hall.
I want to take the duplication. Oh. That's one was my problem. Try to pick me late in the night. So, okay. Okay, not bad. I have most of the things I want to talk about. Let's skip this. That's been limited in the getting to the end. That's okay.
You need that. Good. The pointer. The middle one. The middle one. Yeah, okay. On the progression. Okay. So this one is forward, backwards, then the pointer up. Then also I told Juma that I want to do like also images that I want to show on my computer. Maybe I should bring it here. Oh, okay. Probably if you start charging it just in case. Okay, just in case. So let's move this one a bit. Then when I finish, then we'll switch it. We'll switch it. Have this just to buttress the points. We just switch the. Yeah, we switch the ATM. The HDMI. Okay. Yeah, that'll be where this HDMI is thick, will it fit? No, it's not. It's we just this one. Where is thick? That's where the other one is.
I think it would. Yeah, we'll just take. Or we can use the VG. The VG. We can just take this one.
It doesn't work. Yeah. But this small one that you're using, it's like the phone one.
Yeah, now the
new
the new MacBook has just one USB port, so you just have to buy an adapter which has the ports on them. So without this one, you cannot connect anything to this. You can't connect a pen drive, you can't connect anything. Just one port. This is the MacBook Pro. It is a MacBook.
So it has only this one.
It has only this one, so you have to connect an adapter to it anytime you want to use it. Yeah, so you buy the
So
adapter.
me, I don't have some.
No, yours has the ports already, but for them, they don't have those ports. So around it, there's only one port here for connection. That's the difference between the MacBook. The other ones have ports. The MacBook Air and the MacBook Pro have ports, but this one is purely MacBook. There's no additional to it. So when you buy it, then you have to buy all these and that adapters.
It's not automatic.
No, it's not automatic. No, it doesn't come with it. You have to buy it. It's just business.
Hello? Hello? So, with the evaluation forms, we've given you an extra one, which is more of an overall evaluation with much details. So you do the two. The first one assesses more of the presentation, the presenters. And then the second one is the overall evaluation of the conference organization. So, ladies and gentlemen, if you have enjoyed or are enjoying our scientific sessions so far, it has been put together by the scientific committee, which is made up of Dr. Jared Oblite, Dr. Kofi Amedi, Dr. Amineba Williams, Dr. Benjamin Sarkodie, and Dr. Bo Okra. So they have put our scientific sessions together, and I think they've done very well. Can I please put your hands together? Our next session, presentation, will be taken up by a consultant radiologist. Is the immediate, for those of us who do not know, is the immediate past president of Ghana Association of Radiologists, and is a senior lecturer I always get this name wrong, so I take my time. University of Ghana School of Medicine and Dentistry. I hope I'm right on that. It's also with the Acute House. It's going to present on imaging for pulmonary embolism. Ladies and gentlemen, shall I put our hands together for Dr. Edmond K. Rakunyapa?
Thank you very much. A quick point of correction. I'm not a senior lecturer, I'm a lecturer. Just before we start. I'm going to talk about pulmonary embolism DVT. It's a very short lecture. Fortunately, unlike my other colleagues, I don't have much to talk about. Just a few things. Just like my life, don't have much to say, don't have money, so we can't even get a girlfriend because there's nothing to talk about. So, yeah, pulmonary embolism. Just a few things that by the time we all live here, as people who be looking at images, radiologists and non-radiologists are like, there's a few things we just have to try and remember. One, we are looking for emboli, so we need to see filling defects. That's the main thing. We need to see filling defects. Two, you might see an area. Let's see.